This week on the BackTable podcast.
I was already in there for the angiogram. I was already ballooning for something, and I used the balloon to occlude it and injected thrombin. And it was a broad-based aneurysm. It probably had a higher risk of embolizing than most would. And it didn't embolize, and I was able to leave the balloon up for as long as I wanted, really. And I think that there's also less risk in the dialysis segment of embolizing. You know, you send something down to a terminal artery in the leg, you got a problem. Every time we do a declot, we're sending something to the lungs on these. And so it was fairly risk-free. It worked great, and I just continued to do that. Economically, though, it doesn't work well in the outpatient setting, but it was worth it to me at the time to not be rubbing referrers the wrong way on the stenting issue, and because I was happy with what the outcome was. When I went back to the hospital after that, I brought that practice with me, and I've adapted it to other locations as well.
Today, we're going to be discussing thrombin injection for pseudoaneurysms, a straightforward procedure that, at least in my experience, pretty common in our day-to-day practice. And so to help me with this discussion, I've invited Dr. Gabriel Werder on, practicing interventional radiologist in Florida, also former IR fellow like myself from Georgetown. Gabe, welcome to the show.
Thanks for having me.
Yeah, man. Thanks for coming on. All right. So just real quick, background and what your current practice looks like right now.
Like you said, I went to Georgetown for fellowship with you. Or not with you, but I went to fellowship at Georgetown.
Did you train with Banovac?
Yep, Banovac was there. He left to go down to Vanderbilt the year after I was there. So had my time with Phil.
Okay, good.
After that, kind of steadily moved down the East Coast, practiced for a little while in Virginia Beach, then in Atlanta, and in 2018, finally made my way down here to the Space Coast in Florida. I've been mostly in hospital practice. I've done some outpatient work. And then May of this year, finally transitioned out of the hospital, and I'm doing exclusively OBL outpatient work, mostly peripheral arterial.
Really? How is it? How's the transition been going? Is the grass really greener in the OBL world?
The grass is really greener. I can probably make what I was doing in the hospital in just a couple of days a week. No nights, no call, no weekends. The grass is greener, and it's rewarding work. I really enjoy what I do on a daily basis.
That's fantastic. How did that opportunity come out? Is it like within, like, did you put your own shingle up, or are you working with like a hospital? Like, how did it kind of play out?
A friend of mine, a rep, in fact, came to me one day when I was not looking at all and said, I got a buddy I want you to talk to about this job, and called the guy up and said, sorry, I don't really have the bandwidth to take anything else on. At that point, it was just, a little bit of side work. And he said, all right, that's cool. Let's just meet up, have a beer. We won't even talk work. And at the end of it, I signed up. And ever since then, we did maybe 2 days a month when I first started, and we've moved along to steadily increase and are now a couple of days every week. My business is continuing to grow.
Yeah, that's what I've heard, especially when you're talking about the PAD space. There's just a lot of good work to be done. And what about adding on some of the embolization procedures like GAE?
We're doing GAE.
Oh, okay,
yep.
Cool.
We just started GAE. I'm not really a big fan of doing prostates outside of a place where I've got cone beam if I need it.
Got it.
And so exploring the idea of getting back into the hospital to bring some of our patients that need things that we can't do in the outpatient setting. But that's, as you know, complicated with exclusivity and, other hurdles.
All right. Well, that's very cool. All right. Good sidetrack. So let's just get into the procedure. Thrombin injections for pseudoaneurysms. The first questions I have is, what locations have you done? Like, where have you seen pseudoaneurysms that you've treated?
By and large, the overwhelming volume is in femorals. I mean, that's kind of where they occur. But I've got the opportunity to do some unique ones. And I've done a handful of radials, and those, the real estate's just a little bit more precious when you're dealing with the hand. Have done a couple of pedals actually as well, and then some more off the wall ones. I caused an intercostal artery injury doing a thoracentesis, and ended up bringing the patient to angio, unable to get into it endovascularly, and in kind of a Hail Mary through an ultrasound probe up there where I could see the blob on angio, I was able to get in and fix it. And truthfully, the whole thing would have taken a tenth of the time if I wouldn't have even messed around with angio, but it wasn't on my radar until then.
Of course. Actually, I've had a similar experience in that, I was trying to kill myself doing something with angio, and then I was like, what if I just did thrombin injection, and then I put the probe down. I was like, oh my God, this is so easy. So
Right.
yeah, like that's actually one of the things I hope people take away is that like think thrombin injection. Any brachials? I still have some docs at one of the hospitals I work at that like to do brachial access, and so I've done a couple brachials.
Brachial access is fraught with
Yeah.
pseudoaneurysm formation, but fortunately, the folks who I practice with aren't doing enough of that to have it come across my table. I've done in the arm a number of hemodialysis accesses. One other is at a rectus sheath. It was
cool.
Somebody that on anticoagulation wound up with either a spontaneous or secondary to mild trauma, a pseudo there. Did the angio again, either couldn't find the feeder or couldn't get into it. After having had that experience with the intercostal, decided, what the heck, it can't hurt to throw a probe on. And that one was staring me right in the face, like you said.
That's great, man. I hope that this is like the takeaway. If the podcast ended now, like I think that we've done our job. But like by and large, common femoral artery, the most common location, right? By and away.
By and large.
Yeah. How about, have you ever run across like any realistic contraindications to the procedure or ones that you've passed on?
No, these folks are entirely, well, for the most part, going to be anticoagulated and likely to have anticoagulation ongoing after the procedure. The only time that it wasn't one of my patients that I heard about somebody that should have been an absolute contraindication, but of course there's no way to know it up front, is a bovine allergy. And a lot of these, the recombinant thrombin comes from bovine source. And I'm aware of one patient who had an anaphylactic reaction.
Oh, really? Anaphylactic reaction? Holy cow.
Holy cow.
That was unintentional. Yeah, so some of the things I wrote down were, bovine allergy, infected pseudoaneurysms, if you knew that ahead of time. I've actually had some cases where it was questionable whether there's an overlying cellulitis. Sometimes I think that clinical picture is muddy, and a lot of people will say it's an overlying cellulitis when it's just like taut skin, like from the hematoma. And in those cases, I have tried to go into some of like, if I can avoid it with the ultrasound may be over like kind of the taut edematous skin, but then I'll try and take a route like through some of the more normal tissue to get into the pseudoaneurysm. And then one of the things I wanted to mention and put a finer point on is that a lot of these patients are on anticoagulation, and you don't stop anticoagulation. Like that's like there's no indicator, or in our opinion, there's no reason to stop any anticoagulation for this procedure, right?
I don't. And I've had a patient once who was on dual antiplatelet after their peripheral arterial intervention. And when I injected the thrombin, she immediately reported an electrical tingling-like sensation down that foot. And I repeated the Doppler, everything looked okay, but just because she immediately became symptomatic, I was a little bit nervous. And so despite the fact that she had minutes before had a pseudo, I ended up putting her on heparin, keeping her overnight just to make sure, and she did fine the next day.
Okay. I've actually had a similar experience where I was injecting thrombin, and I don't know if my patient was saying my foot is tingling, and I could feel both the DP and PT pulse exactly like it was baseline, put a Doppler on it, looked good. But that patient was in-house, and we just kept her over. Continued to keep an eye on her, and she did fine. So what else? Okay, so now what does your setup look like in terms of like, do you use a stopcock, connection tubing, like whenever you're getting prepped and ready to go?
I treat all of these like I would any case. The overwhelming majority of them are done in the hospital setting, and so I just have a traditional sterile prep and drape done. I wear a gown, I wear gloves, wear a mask, and then I don't use a stopcock and I don't use tubing. What I do is use a spinal needle or another styletted needle, depending on what's available. And the reason that I use that is because once you get a little bit of bleed back into the barrel of that needle, it's easy for clot to form in there. And I don't like to have to use a lot of force with the syringe when I'm injecting, because that's a recipe for embolizing. So it's a nice backup to have that styletted needle to be able to clear the barrel and then go back to injecting if you still need to.
Whenever you're using the styletted needle, what size gauge?
Typically 21 or 22. And to be honest, I can't even recall. It's the black spinal needle. And I think that's
same,
21.
22. Oh, really? I was going to say 22.
Is that 22? Maybe it is. Yeah.
I don't know. Actually, it could be the 21. I always thought, let me think. My 21s are green. My 22s are really spinal. My yellows are 20. I think it's 22. But either way,
right,
21. Either way, 21 or 22, I think gets the job done. Also agreed, like the styletted needle. And then let's just then talk about how you drop your thrombin and then what dilution you use.
So we use the 5,000 unit kit that comes, and we dilute out the whole amount. It's not like Varithena or something where you might want to split the dose among a bunch of people. And so what we do is we dilute out the total amount, and then that's a 5 milliliter syringe that gets 5 milliliter total volume. We then put that into like a reservoir syringe, and I'll use a 1 milliliter polycarb if we have it available, but any syringe is okay. A 1 milliliter syringe in order to put the amount that I intend to introduce, and that's 1,000 units. Typically, I like to try to get away with around 250, and I've seen that kind of reported as you don't want to be going higher than that. It's seldom that I can get away with only putting in 250, and I'm usually putting in somewhere between 300 and 500 total.
So your volume of injected, is it 1,000 per ml, or you're doing?
It's 1,000 per ml, and they have a 1 ml syringe that's filled.
Got it. Okay. I do something similar. So I have the 5 ml or the 5,000 units and the 5 ml kit. So I'm at 1,000 units per ml, and then actually dilute that further. And I'll just use, and it's just different practice patterns. I can't say that one's right or the other. And I'll dilute it to like 200 mLs 200 units per ml. And I've just, like, I remember actually I was at Georgetown and Alex Kim, he's like, I think we're using more thrombin than we need to. And I've done it both ways, and I've been able to thrombose every pseudoaneurysm that I've ever been into. And it happens like remarkably quick, whether I'm using like a full strength or a kind of diluted one.
Are you able to stretch the dose and use it elsewhere, or are you still burning 5,000 every time you open it?
I'm still burning 5,000 every time, so it's not like I'm even saving anything. I've just played with it both ways. So one of the other things I was going to talk about is how important setup is. You already mentioned like you treat everything like a real case. In my experience, a lot of the patients who have had to deal with, there's kind of a reason they had a pseudoaneurysm. A lot of it's body habitus, and so I spend actually a fair amount of time on the front end, just getting everything set up, like taping a pannus up if that's necessary. Sometimes I'll have some like the pannus taped up, and then I'll have someone hold the leg in a certain way where it kind of stretches and elongates that skin and around the groin, so I can have like a nice clear short distance to get to the pseudoaneurysm and be able to see it and document it pretty well just on the diagnostic pictures. Any tips as far as that goes?
No, I do something very similar to you. The only thing that I'd add is that because I do a Doppler beforehand, keep the vascular sonographer there for guidance during the procedure, and then repeat the Doppler afterward, I don't like to have them bend their hip right after I've injected the pseudoaneurysm. And so if it's, in terms of positioning, I often will think about interrogation of the popliteal afterward and make sure that we don't have to bend the hip in order to get to that. And that might mean propping the foot up on some pillows or something like that, just to get space underneath the leg to see the popliteal.
Okay, nice. As far as sedation, do you ever use any sedation or lidocaine only?
Lidocaine on everybody, sedation only on those folks that have some type of extraneous circumstances, either maybe they're not mentally there enough to understand exactly what's happening and need to be relaxed further, those type of circumstances. But typically the procedure itself, I don't think requires it.
I totally agree. Actually, you should take a pretty hard line and just say, this is minimally invasive. It's a 22 gauge needle. There's nothing painful about it. But what I have, like I've kind of softened in my older age, and that, sometimes like this area is just very painful, especially like one I can think of like a brachial artery pseudoaneurysm, and the patient was just hurting so bad just to even get their arm in a position where we could get to the pseudoaneurysm. We did sedate, and since then why not sometimes if they're in PO and then it's safe, go for it.
I have a tremendously low threshold for sedation in general.
Right. It's gotten
sedated
lower.
Thyroids and thoras, and these folks, particularly on the femorals, a lot of them, because they've got that body habitus and because there's bleeding, that area is exquisitely tender.
Yes.
Some of them have skin breakdown from having had a fem stop or something on, and I'm sympathetic to how they present, and if they want a little sedation, I rarely decline.
Same. Feel exactly the same way. What about your ultrasound evaluation? Can you speak to like how much time you spend scanning the groin or the pseudoaneurysm beforehand, and like how you check pulses before and after the procedure? Like, you just palpating? I know you mentioned that you check the pop and make sure the pop's accessible. Can you speak to that a little bit?
I can. Yeah, I don't do the scan myself. I'm fortunate to have really great vascular sonographers. And in the hospital that I most recently practiced in, the cardiology was the greatest source of pseudoaneurysms, great business referral. And the vascular sonography team, as opposed to the rest of the sonographers, were also under cardiology. And so everybody viewed it that you were doing them a favor to come over and treat this case. And so the vascular sonographer would start out with a routine Doppler, and I wanted an entire exam for the pre. I'd get the size of the aneurysm sac itself, a diameter for the neck, and a length for the neck, which, as you know, oftentimes they can't really find that, but
sure,
to the best of their ability. And then I didn't care about velocities because we weren't looking to, document stenosis or anything like that. What I wanted was a waveform and patency of all of the downstream vessels. And so I'd use that as my baseline, do the injection, and then on the post, if all three infrapopliteals, the tibial vessels, started out triphasic and were still triphasic, that was all that we did. If you noticed a change in one of those, then you're going up to the pop and hunting up the rest of the leg to see if there's something that's an embolized thrombus. And when I dictated those procedures, I would dictate, regardless of if one had already been done, a new diagnostic, a complete peripheral Doppler. Then I'd do the ultrasound guidance and the injection itself, and then I would do a limited for the post, and I would submit charges for all of those. I have no idea in the hospital if any of that was ever collected or not, but at a minimum, I felt that the department would get internally, some type of productivity metric for what was done, and we are doing that work.
Absolutely.
And so I wanted it to be reflected in my report.
Okay. Well said. So getting to the procedure itself, we've talked about our dilutions. You talked about 1 ml syringe, polycarbonate if available. Whenever you're sticking, will you speak to a little bit? I have a couple scenarios, but single, nice pseudoaneurysm, nicely sized, long, thin neck, where do you stick, like with the pseudoaneurysm?
I try not to be doing unusual things like coming from above or from the side. If I can come from below the pseudoaneurysm the same way that you would for a retrograde common femoral artery stick, that's what I do. And there's been, I think, historically a lot of debate about whether you position your needle at the junction of the neck and the sac, whether you position it at the dome, or whether you go right in the center. And I really didn't ever worry too much about that. I kind of just did technically what was easiest, which was the center. And then a couple of years ago, there was an article that came out saying that there was a statistical advantage against embolization for doing exactly what was easiest and putting your needle right in the center. And so I've been evidence-based this whole time without knowing it.
So I actually, on prepping for this podcast, and I'll try and link to this journal, but there was an article out of the Journal of Thrombosis and Hemostasis, a journal that I have not heard of.
You're right. Yeah.
Yeah. And it said exactly what made me feel good, like just go for the center. Because I know that, like, in theory, it's like, okay, target the head and neck junction or target the dome. And, sometimes that's very possible and it's easy and you have total control of the situation. But sometimes just like hitting the center, it's the easiest. And so, yeah, I would echo that sentiment. I've been practicing evidence-based medicine without knowing it for a while. So once you have needle in position, stylet needle, pull the stylet out and then just attach the syringe and then just kind of puff it in nice and gentle, nice and slow as you're watching under ultrasound.
What I do is I find that it's difficult sometimes to get to visualize my needle tip or to get it there with color. And it's much easier to see with grayscale. Similarly, it's really easy to see the pseudoaneurysm with color, but oftentimes you might not be able to see it with grayscale. And so what I do is I switch back and forth a lot on my approach. Once I've got it there, the needle into the center, I leave color on the entire time. And then I try to compress with the ultrasound probe if I can, so that if I can compress to the point where we don't have any inflow or outflow, then I feel great about just, putting in 250 all at once, letting it sit there. And then I let up pressure after about 30 seconds or so to see if, after you see some of that echogenic thrombus forming in the sac itself. And if color doesn't return, you're done. If color does return, then I'll recompress and maybe reposition the needle if the area where I've got the needle tip is in thrombus and there's color elsewhere, but then just finish the job, kind of repeating the same process as before.
I would say nothing to add for me. Do exactly the same thing. How about if you have like a complex pseudoaneurysm, like there is a superficial pocket and a deep pocket? How do you approach those?
I will start with the most superficial, and that's just because there is a school of thought that if you start the closest to the source, that, with less thrombin, you may clot everything else off. But I also feel like your risk of embolization closer is greater. And so I'll take a chain of lakes type of a pseudoaneurysm in a piecemeal from the furthest from the source first.
Yep, same, exactly. The other question I was going to ask, and this is actually the reason I reached out into the first place, I was looking on SIR Connect, and somebody was asking about balloon occlusion thrombin injection, and you just had a smart, thoughtful post. And so I was going to ask you about, not that you have like a wide case series on this, but kind of how you do that and why you did it for that patient.
I assumed you reached out to me because this is the most technically challenging and sexiest of all IR procedures.
That was also it, Gabe. That was also it.
Yeah, so I'd consider that an advanced technique as far as advanced techniques inside of pseudoaneurysm injection go, and that crept into my practice fairly organically. I used to work in an outpatient dialysis center and had a patient come in with a graft and several wide-mouthed pseudoaneurysms, broad-based pseudoaneurysms, and had non-healing ulcers over 2 of them. He had an outflow lesion at the venous anastomosis. I treated that, looked great. It was much less pulsatile. He came back and had worsening of the ulcers, but no more prolonged bleeding or anything else that suggested that the stenosis was there. I repeated the angio, and the stenosis had not recurred. And so I relined the entirety of his graft with a Viabon, and the ulcers did heal, and he also became, quote unquote, difficult to cannulate. And so I don't know if what happened was, my thought process was that somewhat like superficial venous insufficiency, there was local pressure alterations near those pseudoaneurysms that was impairing healing. I don't know if I was right, or if maybe his diabetes became better controlled, or what I suspect is that when he became difficult to cannulate in those pseudoaneurysms that they were using, all of a sudden they stopped sticking and he had an opportunity to heal there. At that time, stenting in outpatient vascular access centers was kind of scrutinized, and I think for economic reasons, some people were over-stenting. And it's not a good look in a referral-based standalone practice. If somebody comes to you, you stent them, they go back, and now they're difficult to cannulate. And so what I did on the next patient that had something similar like that was, I was already in there for the angiogram. I was already ballooning for something, and I used the balloon to occlude it and injected thrombin. And it was a broad-based aneurysm. It probably had a higher risk of embolizing than most would. And it didn't embolize, and I was able to leave the balloon up for as long as I wanted, really. And I think that there's also less risk in the dialysis segment of embolizing. You know, you send something down to a terminal artery in the leg, you got a problem. Every time we do a declot, we're sending something to the lungs on these. And so it was fairly risk-free. It worked great, and I just continued to do that. Economically, though, it doesn't work well in the outpatient setting, but it was worth it to me at the time to not be rubbing refers the wrong way on the stenting issue, and because I was happy with what the outcome was. When I went back to the hospital after that, I brought that practice with me, and I've adapted it to other locations as well.
So if you've adapted it to I think the case that you talked about on SIR Connect, was it a popliteal artery?
I don't remember this, actually.
Oh, okay. Well, so I forgot. So will you talk about how long you leave the balloon inflated, or kind of how you did it? I'm going to look up the SR Connect thing.
Okay. Most of these being femoral, that's where I've done most of my balloon-assisted thrombin injections. And what I'll do is I'll go up and over from the contralateral side. If it's somebody who's a really difficult to access, if I'm accessing through calcium, something like that, where I'm concerned about causing a second pseudoaneurysm, I'll occasionally even just bareback it. But usually you can get away with a small sheath, 4 or 5 French. I'll go up and over, then move to a lateral, because all of these injuries are on the anterior aspect of the vessel where the other operator or yourself accessed. And so I'll go into the lateral so that I can kind of see angiographically what the neck looks like. Occasionally I'll notice that these are, typically they're only in the angio suite because I had suspicion that it was a broad-based aneurysm. Occasionally I'll find that it is indeed narrow-necked and easy, and I'll just, I won't even bother with the balloon, just go straight up to thrombin injection. If it is, as I suspected, something that's a little bit more fraught with the opportunity to embolize, I'll put up a balloon that's slightly oversized. Maybe the vessel looks to me, I'm not using IVUS or anything like that, but if the vessel looks to me to be about a 7 or an 8, I may use an 8 or a 9 balloon, and could just go up to maybe 2 atmospheres. The balloon being oversized allows you to stay smaller. I'm not looking to get complete stasis. What I'm looking to do is to preserve the vessel lumen and to really slow down the flow that's going in and out of the aneurysm, not necessarily to stop it completely. And I did have one patient like that who I treated, let the balloon down, redid the angiogram, and hadn't changed. I did it again, redid the angiogram, it hadn't changed. I did it a third time, this time watching under ultrasound as I let down the balloon, and just watched all of the clot go right down the leg. And amazingly, 3 times I did that, and I'm assuming the first 2, the same thing happened. The patient did fine, but when she went for a surgical repair later, the vascular surgeon, who a decent guy, but he said, "What? You failed? Like, don't you just do it? I order it and it gets done."
Sure.
Yeah, so he had given me a little bit of flack for that. Then when he brought it in, he came back to me later and said, "I can't imagine that it would have ever been possible. The whole vessel was shredded." And I didn't know if that vessel had started out shredded or if it was my balloon that had done that. And so I already was being cautious about how much I inflated, but since then I probably am even going lower, 1 to 2 atmospheres.
Got it. I'm just going to assume it was shredded before you put your balloon up. Okay. In the cases when you've done the balloon occlusion, then you deflate the balloon, do you do a runoff to check the vessels afterwards, or it's strictly just for the balloon portion and then you just pull everything out?
It's just for the balloon portion, but I did do an angiogram on the front end, and so I bill and code that I've done a complete angiogram, and maybe I don't anymore. I used to do a full runoff in the beginning so that I would have a baseline if they came back. But in most cases, even if a little something embolizes, or as in the case I just told, a lot of something embolizes, most of the time they're asymptomatic. And so I haven't gone looking for something that I'll then feel compelled to fix when I know that going down into the smaller vessels, you can cause injury trying to fix something that may not need it. I wait till somebody's symptomatic before I go after it.
I think that's I think that's good advice. Treat the patient, not the pictures. So afterwards, post-care, I'll just leave it to you. How do you follow them up, if any follow-up?
I don't do any follow-up that is a follow-up clinic visit or anything like that. For the immediate post-op care, my usual practice is to default to whatever the bed rest instructions were that the initial operator gave. And so if they were comfortable with the patient, getting 2 hours of bed rest, I assume that they knew what they did. We've reverted the situation to hemostasis immediately after the procedure. And so I'll reset the clock on whatever the bed rest is that they needed. If I don't have guidance like that, I'll do 4 hours for anything up to an 8 French access. To my knowledge, I've only treated one larger than 8 French access, a pseudoaneurysm from one. And it was, again, one of my own cases. I had a 12 French up and over and had done that for a arterial thromboembolectomy on somebody that had just tons and tons and tons of clot using the 12 French Fenommer device, and used the pre-close technique in order to close in quotes. I ended up with a pseudoaneurysm. And for that one, he already was an inpatient, so I kept him bed rest overnight. As I said earlier, I do repeat the Doppler immediately afterward, and if I have triphasic or at least equivalent to baseline flow in all 3 of the infrapopliteal arteries, then that's the end of what I'm doing. Other than bed rest and the Doppler, I leave it up to the referring clinician for how to follow up with that. If it's my own patient, I then revert back to whatever my follow-up was for the procedure that caused the pseudoaneurysm.
Okay, understood. The only thing I would say that I do differently, a lot of these patients that I treat are already inpatient. A lot of times, if it's straightforward, I do exactly what you do. Simple, straightforward, thrombin injection, no issues afterwards, then I just check it after, then call it good. If it's like a bilobed or complex pseudoaneurysm, or I've treated some that were like what I thought were pretty large pseudoaneurysms, then I've done a Doppler evaluation the next day, not of the lower extremity or not of the leg or anything, just to make sure that there's no residual flow or that it didn't recannulize. And of those, I can just say that there was only one. It was this massive pseudoaneurysm. I'd actually taken him back to angio. I had a tiny neck. I coiled that. And then I brought him back the next day, and there was a little bit of flow left in it. And so I just topped it off with some thrombin. But this was like a massive, I think it was like 10 centimeter pseudoaneurysm following like a trauma patient that ended up in rehab. Strangely enough, like the trauma was like a month before, and the pseudoaneurysm had just been kind of sitting there undiagnosed for a couple of weeks before we got around to treating it. It looked very scary, but the patient was just like, yeah, I'm just a little bit sore in my right buttock. And that was the only symptoms.
It's crazy how they can present so differently.
Yes.
I haven't had the pleasure of treating anything that size, but I certainly think I'd probably err on the side of doing exactly what you did and getting a little additional follow-up.
All right. So did we beat it to death? Did we cover it?
I think we did.
Okay.
Yeah, I was honestly astounded when you tracked me down and said, you're the guy I want to talk to about pseudoaneurysms. And this was enjoyable. I'm glad that you did.
Well, I'm glad that you came on, Gabe. I know that there are sexier topics, but honestly, like sometimes, like, we've covered some really basic stuff on the podcast. We've done ports, we've done cholecystostomy tubes, and sometimes it's just nice to like knock those out. There are a lot of like different ways to do it, and so it's nice to hear someone that's got a lot of reps in, especially like I think in fellowship, like at Georgetown. I just don't remember. I'm sure we did them. I'm sure I did a couple, but you didn't do like 20. I might have done like 5. And then you get
I don't have a long-term memory of having done a single one there either.
Exactly. And that may be actually the case. Like maybe I even did like 2. And so there are these procedures that I felt like in fellowship, I just didn't get a lot of reps on. Like, I mean, I remember coming out into practice, bone marrow biopsies. I'd never done a single bone marrow biopsy. And I got to one of these hospitals, we did them like 3 a day. I was
Same thing.
Yeah. I was like, oh, that's private practice. They're all different. But if younger audience members, if you heard Gabe talk about his practice earlier, it's not a bad route to go. So Gabe, thank you for coming on. To our audience, thank everyone for listening. If you guys enjoyed the podcast but want more, please check out the show notes of this episode. I'm going to at least list that paper that Gabe and I came across. And for others interested in supporting the show, like, subscribe, or share this podcast on social media. We'll see you next time on the BackTable podcast. Gabe, thanks for coming on.
Thank you, Chris. Nice to meet you.
Yeah, nice to meet you also. Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.